Top Med Talk. Hi, it's Monty Mythen here, Editor-in-Chief of Top Med Talk, coming to you with Journal Club. This week we have an article from JAMA. It's entitled The Effect of EEG Guided Anesthetic Administration on Postoperative Delirium Among Older Patients Undergoing Major Surgery. Actually, the EEG is longhand, but that's hard to say at this time in the evening. It's called the Engages Randomized Trial. JAMA 2019, 321, pages 473 to 483. Now, as always, we'll put that full reference in the show notes for you. Now, within the paper, there's a great infographic that summarises the trial design, and I'm going to go through that quickly, then introduce our guest, Desiree Chappell, anchor for Top Med Talk, who's going to have some input on this journal as well. So the question posed by the paper was, does EEG-guided anaesthetic administration decrease postoperative delirium incidence in older patients undergoing major surgery? Now, we know why they do that, because there's been associations between burst suppression, as it's called, or quite low levels of EEG-monitored anaesthetic depth and delirium postoperatively. And to some people, that makes sense. You know, deeper anaesthetic, not so good for the brain, wake up and have a delirium state afterwards. So this is a randomized clinical trial of older patients undergoing major surgery, and they found, cutting straight to the results, that EEG-guided anaesthetic did not reduce the incidence of postoperative delirium. Now, trial design, let's deal with the population first. It is 669 men, 563 women, aged greater than 60 years, undergoing major surgery under general anaesthesia. The median age is 69 years, and of note, it's in a single location. So it's a hospital, it's actually a hospital group in St. Louis, Missouri, in the United States of America. So the 1,232 patients, as described, randomized 614 to get the EE-guided anaesthesia and 618 what's described as usual anaesthesia. So let's deal with the usual for a second. It's anesthesiologists and nurse anaesthetists blinded to the EEG waveforms of anaesthetic depth. What they're describing is the EE-guided anaesthesia, which for some people is usual, as I'll come back to in a moment, is that the anesthesiologist and the nurse anaesthetist viewed the display of the EEG waveforms of anaesthetic depth. So they adjusted, following a training program to remind them how to do this, they adjusted the anaesthetic agents up and down to lighten the level of anaesthesia such the patient was anaesthetized but not deeply anaesthetized. The primary outcome was the incidence of delirium during postoperative days 1 to 5, as assessed by validated instruments or thorough chart review, and we'll come back to that as well. Findings: 26% incidence of delirium, i.e. 157 of 604 patients in the EEG-guided group, and 23% of delirium in the usual anaesthesia group. So there was a 3% difference, not statistically or probably clinically significant, and if anything, the delirium was a little bit less in the group that was not EEG-guided. So, Desiree, welcome. How are you today?
I'm great, Monty. How are you?
Very good indeed. So you're coming to I should have said I'm in the Top Med Talk studio in London at the moment. You're coming to us live from Louisville, Kentucky, from your home. How's it there today?
Yeah. It's great. It's beautiful and sunny, which is very unusual for this time of year in Louisville, but it's also 16 degrees Fahrenheit, which is not always great, but that's okay. I'll take the sunshine, so everything's great.
So this trial, Desiree, you're a nurse anaesthetist, a CRNA, so you're one of the people included in this trial as a type of provider. I'm highlighting that because in the UK we don't have CRNAs, for example. I'm not sure that's at all relevant to the trial, but you commonly use the BIS type of monitoring used here, the EEG, to guide your anaesthetic practice. Is that correct?
Yeah, I do, and I've worked in two decent-sized facilities the last couple years, or last 10 years, and have used the BIS in about 75% of the patients that I take care of.
And if you were selecting particular types of patients to do the so-called BIS monitoring on, are there any ones you choose in particular?
So typically for my practice, I do quite a bit of TIVA cases, so total IV anesthesia, and I use it on all those cases, especially in the last 4 years since we've been doing more enhanced recovery and reducing the amount of anesthetic gases that we give. So all TIVAs, and then, on most of my elderly patients for most surgeries, which is a large patient population. here in Louisville.
Particularly the more major type of surgeries?
Yeah, more major. I mean, even some of the not as, minor cases but still last a while, I'll still use it. But, yeah. And
when this will all become relevant when we come to discussing the details of the paper, which I've had a really close look at. I know you've had a look at it as well. But when you're using the BIS monitor, what are you trying to achieve? And that's a big old question, but
yeah.
Is it that you're trying to stop anaesthetic overdose, or you're factoring into some of your other management decisions?
Yeah, I think for me, the BIS is another tool. It doesn't completely, I don't live and die by every number that comes across, but I do use it to help guide, especially on those frailer patients, elderly patients, if they're having some hypotension, things like that I can titrate the anesthetic and lighten them up a little bit and hopefully can control their blood pressure a little bit more closely with that. So that's typically how I use it. There are some cases whenever we're utilizing it for, a true depth of anesthesia. But, for the most case, it's to help guide hemodynamic management and other things that I'm trying to do in the case.
Okay, and that resonates with me. So when you heard the headline results of this trial, were you surprised?
I was a little bit, yeah. It's one of those things that I kind of, when we talk about utilization of BIS and cognitive dysfunction and delirium after surgery, there's not a ton of research that supported that, but I was just as in curiosity with the post-op delirium was hoping that it might be a good way to help deter that, but it didn't.
So let's go through a little bit of detail of the study to see if we can rationalise any of those by your evaluation surprise findings. So as we said, single-centre trial, older patients, so median age 69, so very much like the group that you're using on, mainly major surgery, but of note, and that's drawn out in discussion, not really the TIVA population here. So this is a general anaesthetic using a volatile anaesthetic agent. It was titrating the volatile anaesthetic agent to try and reduce the amount of volatile anaesthetic agent in one group and hopefully therefore have less delirium. And without torturing the results, they're all there to have a close look at. I think an extremely well-conducted trial. I've been through it in a fine-tooth comb, and all of the elements you'd look for it being high-quality research, acknowledging the fact that it is single-centre, which we'll come back to. It looks extremely well performed, the groups look extremely well balanced, and it's a massive effort. Now, one thing that one's eye is immediately drawn towards, which a lot of people have been discussing, is what looks like a big difference in mortality. Now, it was a stated secondary outcome variable, so legitimate to report it, and I think legitimate to highlight it as a result in the abstract. And just to draw close attention to that, within 30 days of surgery, 4 patients, i.e. 0.65%, in the guided group died, whereas 19, which is 3.07%, in the usual group died. Now, that strikes me as a very big difference. What did you think about that, Desiree?
Yeah, whenever I was looking through it, that was not an outcome that I expected at all, especially when you're reading kind of some of the other morbidity and issues with the outcomes. So, yeah, definitely.
Now, we know we have to be careful in drawing too much attention to that because it wasn't powered. The study wasn't powered to address that question. Yeah. So this could be an error, a classical error where as a result of inadequate numbers you get a chance distribution of the patients. But I'd still like to explore that a little bit further. And in pursuing that, what sort of things would you be looking for to try and understand if that was a real difference? Actually, I'm going to back up a little bit. Let's talk about a little bit of face validity. As we go through the trial, I just wanted to jump straight into this mortality thing, but let's do the usual stuff that we're supposed to do. Table 1, patient characteristics, all look extremely well balanced. Figure 1 is worth noting because the consort diagram in there highlights how many patients had to be screened to end up with the number that were randomised. So 39,144 patients were assessed for eligibility, and 2,564 were deemed eligible. So important to remind ourselves that this represents a very small subset of the patients that we might look after. But we kind of know that this smaller group of very high-risk patients brings with it a lot of problems, a lot of challenges, a lot of morbidity, a lot of the death, and a lot of the expense. When they are randomized, that all looks as though it's extremely well balanced. There is some elements there that make us think, well, this is what I'd expect in my practice. So, for example, in Table 2, the end-tidal volatile agent concentration, the MAC, is statistically significantly and possibly clinically significantly lower in the group that has the guided therapy. And that's what you'd expect, isn't it, Desiree? You'd expect to end up giving a little bit less agent as a result. And do those MACs look about right to you? Is that what you'd expect?
Yeah, for this patient population.
About 0.7, 0.8 with a mixed anesthetic technique. Is also the duration of those patients with a BIS less than 40, which is like this very deep anesthesia, is also different between the two groups. And that, again, has that sort of face validity. That looks right. But the other thing that perhaps we shouldn't be surprised at is the intraoperative dose of phenylephrine is quite a lot lower, I suppose, 1.37 milligrams compared to 2 milligrams. There's a few other nuances in how that data is presented, but there's a difference between the two groups. Now, not everyone who's listening is going to know all about how these anesthetics are given. Is that what you'd expect? Would you expect this drug, phenylephrine, which is given to treat hypotension, to be given less often if the volatile anesthetic agent is turned down?
Yeah.
So that's me. And that overlaps with what you were saying is in your practice, one of the reasons you're using the BIS is if your blood pressure is down, you want to know how far you can turn down the volatile anesthetic agent without the patient waking up, to put it crudely.
Yeah.
Is that right?
Exactly. Mm-hmm.
Then the other thing they tell us in their adverse events, they highlight the fact that there was more, as they describe, as undesirable intraoperative movement. So one of the issues you're flirting with is if you lighten the anesthetic, the patient may be more likely to move during surgery, implying the fact that they're not completely anaesthetized. Does that make sense too?
Yeah.
And does that mean that they're awake?
No, that's what I was just going to say. Sorry, I was like, I'm like looking at the table here. No, that's one of the common things in misnomers, that they're asleep. They may not be paralyzed, and if they lighten up, they may have a little bit of movement, but it is totally a common theme. Okay,
and there's a longer debate for another day as to whether they're truly anaesthetized or not, but none of them had intraoperative awareness. So
awareness.
So 0% in either group. Now, I'm going to come back again to this mortality thing. So if you go into Table 3, that is one of the striking features, is the mortality up to 30 days after the surgical procedure, 4 out of 614, 0.7%. 19 out of 618 is 3.1%. Now, we're sort of in the ballpark of the mortality you might expect for these high-risk patients if we look at other trials. But one of the questions I would come back to, which I know a lot of people are discussing, is might that possibly be true? And then I think we'd look around for other clues. And one of the things they decided to look at in detail was the incidence of perioperative hypotension. Something we've discussed a lot during TopMed Talk is this risk, a low MAP associated with poor outcomes, and therefore one might think that the group that had guided therapy would have fewer hypotensive episodes. But again, that's not what the trial showed. It did show that the patients who had guided therapy received fewer vasopressors to keep their blood pressure up, but there didn't appear to be a big difference in the incidence or duration using the methodology they used for hypotension. Now, I'm going to take us now. Can you get to the supplement there, Desiree? Which I think
that's what I was just pulling up.
Is really, as Manu Malbrain and colleagues in their editorial wrote, appendicitis. It's important to make sure that you, if you are really interested in the results, have a good look at the appendix as well.
I have to tell you, Monty, like one of the things that I have learned from our journal club is to look at the appendix. It's not something that most people do. I mean, I never did.
Well, I'd say for Lots of interesting information there about patient demographics and levels of earning. If we go down to Table 2, which is the preoperative health conditions, the comorbidities, they're a pretty sick bunch. Look at their Charlson Comorbidity Index. There's a spread there you might anticipate. Many of the patients up to the 4 to 6 plus area. High incidence of coronary artery disease, as you might expect, about 40% or so, 20% congestive heart failure, 45 to 50% valvular heart disease, and so we go on down to hypertension, running at about 75%, which again is what one might anticipate, and about 23% with chronic kidney disease. I could go on, but there's this typical elderly, multi-pathological, presumed multi-pharmacological group of patients that represent quite a significant risk. But I want to concentrate on that hypertension for a second, because that leads us down the rabbit hole of the blood pressure question. If you now go on, there's lots of other things we could discuss here that are of interest, regards not an imbalance in the groups, but just regards to the demographics of these patients. But in the interest of time, we will jump down to Table 6. Now, Table 6 contains the vasopressors and inotropes used. And can you get down to that section at the moment now, Desiree?
Yep, I got it.
So you've got the hypnotic agents, opioids, neuromuscular blockade. You get to the vasopressor and inotropes. Now, this is often, as we discuss quite a lot about hemodynamic management here, there's quite a lot of people say to you, well, you're really going to start a so-and-so infusion, or I don't give very many vasoactive agents. But as we've often highlighted, when things are written down properly in a trial, almost everyone's getting vasoactive agents. Okay. So in both groups here, more than 80% of patients are receiving phenylephrine. And we're not surprised at that, really, are we?
No, I would say that's not a huge surprise at all, especially in this patient population.
Yeah. And about a quarter to a third are getting ephedrine. Yeah? Yeah, not surprising. Yeah. Possibly surprising to me, about 16% are getting dobutamine. I didn't expect that.
I was surprised at that. but these are also, there's 40% of cardiac. These are 40% cardiac patients.
Exactly. There's a big old mix in this, so perhaps we shouldn't be surprised at that. And 40% are getting norepinephrine. But as you say, there's cardiac patients in there as well. Right, so let's get to me was the bit that I'm very interested in as a possible route for further explanation. If you go down to Table 7, it's the intraoperative cumulative durations of low stroke high mean arterial pressure and heart rate. Now, because of all of the discussions we've had about hypotension, and we've done plenty of that, and this threshold of 65, I can understand, it's exactly what I would have done, why they went after the hypotension and durations of hypotension. They've chosen thresholds of 75, 70, 65, 60, and 55. So concentrating on the less than 70s, there's no difference between the two groups of the cumulative durations of being under those thresholds. Am I reading that correctly, Desiree?
Mm-hmm.
If you go to the less than 75, it's possibly starting to get a little bit more interesting, because there now is an imbalance with a p-value of 0.09. So it's only a small separation, about 76 in the guided group, and 81 in the other group. So, longer duration of being under a higher threshold than the one that we've been told to worry more about of 75. But then the probably more striking thing is how long patients spend above a MAP of 110, 115 or 120, and those are statistically significant differences. So if you're interested in this whole area, please do look closely at that table. Now, I think we wouldn't be surprised if we were asked to predict what would happen if the patients who are having their volatile anaesthetic agent turned down ended up with higher MAPs. And as they're there's a very high prevalence of hypertensive patients, perhaps we wouldn't be surprised if their MAPs are getting up above 110, 115, 120. So the obvious question there, which we can't answer from this paper or require further studies in the future, which we know are ongoing, is were those deaths in any way, shape or form related to the fact that the patients ended up possibly having longer durations of higher blood pressures? Am I reading too much?
Yeah.
I'm not saying that's what this paper tells us, Desiree, but that's the hanging question for me. Is that death difference real, and does it some way relate to that phenomenon?
Yeah, I mean, it's clear to look at the numbers that there's definitely further questions, that need to be asked. But I think that's a fair question. It's a fair question.
And as I say, we can't, and we should in no way suggest that we can answer that question from this great paper. But I think there's lots of extra information involved in this trial, which is a huge endeavour to possibly guide us in the trial and design of future studies. So is there anything else you picked up in that bit, Desiree, before I go to the editorial by Abbott and Pierce?
No, that was pretty much it.
I'm sorry to bang on again. It's just on table 13 goes through the adverse events by body system. And once again, sorry to pick on the Minzers, but there aren't many myocardial infarctions, but there are plenty of GI tract infections, ileus, sepsis, and pulmonary events are one of the dominant things.
But
so
I would say pneumonia, pulmonary, All
so
those things,
again,
stroke.
this thing is we're saying we don't know what the MINS rates are because we're not measuring MINS, but the pattern of morbidity as we might expect. So let's jump then in closing to the excellent editorial by Tom Abbott and Rupert Pierce. Have you got that up there, Desiree? So I did my full review of the paper and did all that highlighting, etc. before I looked at this, and not surprisingly, I think we all agree with each other. There's a nice summary editorial there highlighting some of the minor weaknesses, the major strengths, and some of the hanging questions. So you will find that we'll put the reference for that in the show note as well. Same edition of understandably JAMA, February 5th, 2019, volume 321, starting on page 459. Tom Abbott and Rupert Pierce, colleagues from the UK, entitled Depth of Anaesthesia and Postoperative Delirium. So they pull out a few points. One is they highlight the fact that it's unusual for a single-centre trial to be published in JAMA, if it's a clinical effectiveness trial. However, they also go on to say, which I completely agree with, is that it's extremely well conducted, leading to a low risk of bias, and it's focusing on a very important question. They go on to talk about the fact that there isn't much TIVA in there, so it may not represent the full spectrum of contemporary practice. Is that a fair comment, Desiree?
Yeah, but I think there's still a fair amount that's being used on, anesthetic cases, which still probably make up the majority of what's happening here.
I think that's what I see as well, is that still most of it is vapor general anaesthesia. Yeah. They then go on to point out that there are other processed EEG waveform technologies available, and it's not a criticism in any way, it's more the sort of standard BBC disclaimer, and that some of them work in different ways that make up different opportunities. They highlight that the primary outcome of postoperative delirium is it's principally a clinical diagnosis, it's various symptoms and signs, so it's harder to capture reliably, but I think they've done the best possible job they can here. They talk about the fact that there was a number of interventions beforehand to reduce postoperative delirium, which evened up the two groups. I'm not sure it's that relevant to the final result. But I just want to come to the fact that they've also drawn attention to this mortality difference and the fact that a reduction in hypotension-related myocardial injury, which may or may not be what was going on here, is probably the thing to go after. So I think we've got good alignment there. So, Desiree, before we close on that, I just want to do as we always do, congratulations to everyone concerned with getting this out there, the massive effort from the authors, etc. Very, very informative trial. Definitely doesn't say don't use BIS. It just says if you use BIS to turn down your vapours, it doesn't look like it's going to affect the delirium rates. Tantalising mortality differences possibly related to hemodynamic management. What else do you make of it, Desiree?
No, I mean, that's kind of the same assessment there. I mean, I think that, hopeful, again, that it might have given us a little bit better picture for the delirium story, but, it's not, which is good. We can, look at other trials that are coming out, I think, in the near future for that to see if this kind of jives with those. I think looking and doing the deeper dive into the hypotension and the other morbidity that is associated with surgery is interesting because we talk about that a lot, and it's not just cardiac; it's everything else. So I kind of really enjoyed looking into the appendix and taking a deeper dive into the patient population and seeing this and thinking again the hypotension story and how it affects not just the heart but everything else.
it sounds as though your practice and your use of BIS, of EEG monitoring, pretty much aligns with what we've taken out of this study anyway. You use it to adjust depth of anesthesia if you think the patient is becoming hemodynamically unstable. Are you going to change anything?
Absolutely. Probably not.
Well, that's reassuring, isn't it?
I mean, yeah, it is. I mean, it's just I'm going to still use it the same way and know that, it's, again, I can't necessarily use it when I talk about delirium, but to titrate everything else, I think it's another tool to have in the toolbox.
Now, in our brain health discussions, we've also touched in the past is that from the discussions we've had that we, with some of our other expert colleagues who we've talked about, is we wouldn't necessarily put the money on the vapor from the point of view of the delirium anyway. It's it would appear to be a fully reversible, probably not brain toxic, compared to hemodynamic instability, compared to blood pressure being below the point of auto-regulation, and probably the big ticket item being inflammation, is that in rank order, can we do something about inflammation, followed by can we maintain flow above the above that auto-regulation point, of which the vapor bit would have been third on the list for me. Was that still where we are, waiting for the trials?
Yeah, I think so. Polypharmacy. Throw that one in there too.
Yeah, well, they've done the bit here of getting rid of the agents that were possibly driving delirium as well as they could. So, great. Well, great trial. Congratulations to the authors again. Desiree, thanks for joining us again. Enjoy the rest of your beautiful sunny day there in Louisville, Kentucky. We'll look forward to catching up with you soon.
Cheers.
Top Med Talk.
Nick Majerison here. Thank you for listening to Top Med Talk. Now, make sure you've subscribed to Top Med Talk on your podcatcher or however it is that you're listening to us at the moment. And you're spoilt for choice. We're on pretty much every single podcast platform you could think of. So make sure you've subscribed. Make sure you've engaged with us on social media, Twitter, Facebook, LinkedIn, YouTube. And make sure you've signed up for our email updates on topmedtalk.com. If you get yourself there, you'll find a website that contains all of the podcasts that we've ever done, and it gives you the chance to sign up for our email updates. That way we can always get in touch with you and tell you what we're up to. Oh, and while you're online, check out edpom.org/meetings. While you're there, get excited about EdPom London 2019, the London Perioperative Medicine Congress. It's on July the 2nd, and it's one of many meetings that EdPom organises around the world in order to communicate the perioperative medicine message. Have a look, edpom.org/meetings.